Hi, my name is Dr. Brandon Silvestry. I'm currently an orthodontic resident here at Roseman University, and the title of my research project that I've been working on alongside with Dr. Joseph Cheever is called The Relationship Between Eating Disorders and the Outcome of Orthodontic Treatment. So to begin, we're going to discuss about the introduction, just a little background on the topic itself. So about over 30 million Americans will experience eating disorder behaviors that include restricting, purging, binge eating, or food avoidance. It is considered a psychiatric disorder characterized by irregular eating patterns and are associated with a negative perception of one's self-image. It is estimated that approximately 6 to 8% of children and adolescents present with some form of eating disorder, likely to impede natural growth and development processes among these groups. The onset of this disorder is usually during childhood and adolescence, around the same time orthodontic treatment is usually recommended. This time frame is considered a critical period in terms of neural development and physical growth, and orthodontic treatment is recommended for the correction of craniofacial imbalances and dental malocclusions during this time. During this literature review, we'll discuss the various types of eating disorders and how it relates to orthodontic treatment, how eating disorders can directly affect tooth movement, and the practice guidelines recommended for early intervention and treatment. The objectives was to assess the relationship and treatment outcomes associated with children and adolescents with diagnosed eating disorders and orthodontic treatment. Our proposed research question was, will patients with diagnosed eating disorders have prolonged orthodontic treatment times due to the oral symptoms associated with this condition? Our hypothesis was essentially that we anticipate the oral and systemic symptoms associated with this condition to interfere with the effectiveness of orthodontic treatment modalities. So for our methods, we provided an overview of peer review articles, case reports, and systemic reviews regarding eating disorders and its relationship to the outcome of orthodontic treatment in children and adolescents from ages 7 to 19. Databases included PubMed, Frontiers in Oral Health, and Medline. The search strategy involved a combination of words including orthodontic treatment, eating disorders, challenges in orthodontic treatment, children and adolescents, shear bond strength, dental erosion, and prolonged treatment time. Selection of research articles was determined by the relevance of the abstract to the proposed research question, design of the study, and supporting information relative to the study. The inclusion criteria included research articles published within the last 15 years and written in English. Due to the limited number of cases, not all studies included had a large sample size. The data collection process involved screening the studies for relevance, compiling the articles, and reviewing them from common themes and gaps in the research. The author's name, year of publication, and study design were reviewed. Documentation of the main finding related to the outcomes of orthodontic treatment by eating disorders was noted, as well as any other relevant additional details. The initial search identified 40 records, with 23 being included in this literature review. Many articles mention eating disorders during orthodontic treatment, but were not directly related to the relationship between the two topics. So moving on to the results section, in order to assess the relationship between eating disorders and how they may affect the progression of orthodontic treatment, we first need to look at the disorder itself and how it affects the oral cavity. Patients with anorexia nervosa or bulimia nervosa, as well as those who have a history of repetitive vomiting, have increased likelihood of irreversible loss of tooth structure compared to the general population of about 8.5 times. One study showed that out of a cohort of 72 patients with self-induced vomiting, 69% of the cohort experienced dental erosion. This is due to gastric acid regurgitation leading to demineralization of tooth enamel, which is a chemical process that causes irreversible loss of tooth structure independent of bacterial involvement. The surfaces affected range from the facial, occlusal, and palatal aspects of teeth. This not only extends to the outer portion of enamel, as it was discovered that about 6 out of the 69% of patients experiencing dental erosion, there were enamel and dental erosive lesions found in 38% of them. Relating this back to orthodontics, we as practitioners must analyze and factor in the morphology of teeth, including the amount of surface enamel present, in order for us to bond brackets upon forward treatment. As we know, orthodontic brackets are exposed to many forces throughout the course of treatment, and so having an adequate amount of surface enamel will help us achieve maximal adhesive bond strength for those brackets. But due to the side effects of eating disorders, it was found that the weakened tooth structure had been associated to frequent bonding failures of orthodontic appliances. This is because there was reduced bond strength and a reduction of the micromechanical interlock between the adhesive material on the brackets to the atypical enamel surfaces. Now, we could also consider the pH levels of the oral cavity as being another factor for frequent bonding failures. During episodes of repetitive vomiting, we see a decrease in the acidity levels of the oral cavity. As the oral cavity becomes more acidic, we see a progressive decline in shear bond strength over time. This suggests that acidic environments, due to malnutrition or poor oral hygiene, may be correlated to an increased incidence of bond failures during orthodontic treatment. Another aspect we found to affect orthodontic treatment in this population group was a low bone turnover state found in patients with eating disorders. It was noted that patients with eating disorders have decreased bone formation and bone resorptive markers, mostly due to the patient's macro and micronutrient deficiencies. This reduced bony turnover can lead to slower tooth movement and longer healing times from dental extractions and orthognathic surgery. Lastly, a meta-analysis reviewing the decayed, missing, filled teeth for periodontal health screenings reviewed that anorexic patients had increased marginal recession, bleeding upon probing, and an overall higher score compared to the control group. There was also evidence suggesting that the increased salivary pH levels coupled with decreased salivary flow caused greater decalcification of teeth and white spot lesions. Greater plaque index scores was also noted, all contributing to decreased shear bond strength of orthodontic appliances. In terms of future directions, I stumbled upon a couple studies relating orthodontic treatment to the initiation of potential eating disorders. These studies suggested that the dietary adjustments during treatment contributed to patients not eating due to fear of prolonging the treatment or even breaking the appliances, as well as pain associated with treatment limiting their ability to eat. The correlation and long-term studies have not been performed, but I think it's an important consideration to think about when prescribing orthodontic treatment. To conclude, eating disorders tend to begin during the same time orthodontic treatment is recommended, usually around adolescence. A variety of oral manifestations have been associated with the onset of eating disorders, potentially contributing to prolonged orthodontic treatment. One must consider all aspects of the oral cavity when undergoing orthodontic treatment, including the patient's periodontal health, caries risk, bone turnover, and balancing of pH levels via salivary flow. Based on the data gathered during this literature review, it can be concluded that oral health can be compromised by eating disorder behaviors, potentially prolonging or delaying orthodontic treatment. Due to the oral side effects associated with eating disorders, maintaining oral hygiene is an important factor for the success of orthodontic treatment. Once severely affected, orthodontic treatment would need to be postponed in order to prevent further harm to the oral cavity. Educating patients with eating disorders about fluoride supplements, xylitol chewing gum, are useful to reduce the effects of gastric acids directed onto the dentition. Although research has indicated weight fluctuations and dietary restrictions during orthodontic treatment, the association between orthodontic treatment serving as the onset of eating disorder remains unclear and needs further research. But it's important to note that a multidisciplinary approach should be used to address any psychiatric disorder in children. Thank you, and thank you for your time.